Hello, everyone. Welcome to another episode of the AABIP podcast series. This is Roger Kim from the University of Pennsylvania Perelman School of Medicine in Philadelphia, Pennsylvania. I'm your host for this episode. Thank you all for joining us today. Today, we will be discussing central airway collapse and tracheal interventions, a likely underdiagnosed etiology of exertional dyspnea. We are very fortunate to be joined by my colleague, Dr. Jarrod Predina, today. Jarrod is an assistant professor of surgery and practicing thoracic surgeon here at the University of Pennsylvania. He completed medical school at Penn before completing a general surgery and cardiothoracic surgery fellowship at Massachusetts General Hospital, where he also received specialized training in surgically managing tracheal bronchomalacia and tracheal stenosis. Welcome to the podcast, Jarrod.
Oh, thank you very much for inviting me, Roger. It's a pleasure to be here.
Before we dive in, Jarrod, do you have any relevant conflicts of interest you'd like to disclose?
No, I don't.
As a reminder, the views expressed on this podcast are those of the speaker and mine alone, and not necessarily endorsed by the AABIP. With the formalities done, let's get started. Today, we'll be discussing central airway collapse and tracheal interventions. While the nomenclature to describe various presentations of this clinical entity have been inconsistent, I'll be using the term expiratory central airway collapse, or ECAC, to describe the broader clinical syndrome, which comprises two distinct pathophysiologic processes. Number one, excessive dynamic airway collapse, otherwise known as EDAC, and tracheal bronchomalacia, otherwise known as TBM. So to kick it off, Dr. Predina, can you compare and contrast EDAC and TBM and describe how you like to distinguish between the two entities?
Sure. And I think what you said is correct, Roger. When people are referred in for evaluation of central airway collapse, people throw around the terms tracheal bronchomalacia and EDAC, and they use them pretty interchangeably. And I think clinically, there's a lot of overlap, which is probably why there's some inconsistency. But when I think about these two processes, I do think that they're different. And I do think that the way we proceed with surgery is somewhat different between the two of them. So for me, EDAC, or excessive dynamic airway collapse, refers to the abnormal anterior excursion of the membranous wall of the trachea, and that obviously moves anteriorly during expiration and obliterates the airway. Now, with the other entity that you had referred to, tracheal bronchomalacia, you certainly see abnormal excursion of that posterior membranous wall of the airway. But I think the hallmark of tracheal bronchomalacia over EDAC is that the cartilage is also pathologically abnormal. And you can typically determine this pretty easily either by a bronchoscopy, where you lose that normal U-shaped configuration of the anterior cartilaginous wall, or even by a CT scan, whether it's a good old-fashioned axial CT scan or dynamic airway CT scan. Again, you lose that normal configuration of the cartilage. And to me, that's the big difference. And we'll talk a little bit more about surgical interventions later on, but what I think right now is the standard of care, robotic tracheal bronchoplasty. That's certainly much easier to do for a patient with EDAC because there's no reconstruction or reconfiguration of that cartilage. Whereas with those patients with tracheal bronchomalacia, not only do you need to stabilize that membranous wall, you need to restore normal anatomy.
Oh, that's all really interesting. And I think we're going to dive into a lot of these different details that you brought up. So thanks for sharing that, Dr. Predina. Some of the classic symptoms typically associated with either EDAC or TBM can include a variety of different things like dyspnea and exertion, a classic seal-like barking cough, and trouble with clearing secretions. However, it's often difficult to distinguish to what degree these symptoms are actually due to the dynamic airway collapse specifically, rather than some other comorbidity like COPD or heart failure, like a lot of our patients have. There are a number of tests and approaches to diagnose airway collapse, some of which you just mentioned, including like the airway CTs, PFTs, bronchoscopic evaluation, airway stent trial, among others. When you're suspecting either EDAC or TBM, what is your sort of algorithm or preferred diagnostic approach that you like to take to get more information?
It's challenging. Like you said, so many of the patients that we see with ECAC have other comorbidities or have been misdiagnosed for many, many years. But I think in general, when I think of the symptoms related to ECAC, I put it into three buckets. I'm going to get to the diagnostic approaches. But again, symptomatically, I think of three different buckets. One are those patients who are plagued with a chronic cough, and that's their primary symptom. Other patients have dyspnea, and I often find this one the most challenging patient population to work out. And then the third one is a smaller group than the other two, and those are patients that have recurrent infections. And when I see these patients, I think the most important thing is, number one, you take a very detailed history and you make sure that each of these other potential diagnoses have been worked up by another primary or another provider. And I think that multidisciplinary approach is essential. Once we begin to think that either EDAC or TBM is a real player in this, I think the two most important studies are an awake bronchoscopy, and then I think a dynamic CT are the two most important diagnostic modalities that we have. The reality is PFTs are often nonspecific, and if patients have other comorbidities, those can be confounded. We'll talk a little bit more about stent trial, but I think stent trials can be important. And when we first started doing these cases over here at Penn, I was insistent on stent trials, but there's certainly confounders that go along with the stent trial. So I think there's a role for a stent trial, but I don't think everybody needs that. Again, I think the most important aspect is a good history. You understand what the patient's symptoms are. You have a good multidisciplinary team so that other contributors or confounders are addressed. And then I think a dynamic CT and an awake bronchoscopy really helps you understand the extent of the disease.
You mentioned using typically both a dynamics airway CT and also bronchoscopy. There has been some discussion in the literature and among experts that in certain situations you can actually just get the airway CT without requiring an awake bronchoscopy. Just given the fact that sometimes due to the severity of the defect on an airway CT, one might make the conclusion that, with that degree of severity on imaging, that you can almost make the diagnosis that way alone. Do you think do you agree with that kind of approach, or do you think that an awake bronchoscopy is almost a requirement to make the diagnosis?
I think that a good CT generally gives you the information you need. The problem is having a properly timed CT is not always guaranteed, so you certainly can miss certain portions of the collapse. And when we do the surgery, we're really only capable of stabilizing the mid to distal trachea, the main stem airways, and we really can't get into the lobar airways. And if I see collapse that's outside of this area of stabilization, I often wonder if stabilizing central airways is going to be sufficient. As it turns out, if you're able to fix about 80% of the disease, patients in general do better. But I do think that the awake bronchoscopy gives you a more accurate lay of the land, and it allows you to understand the true extent of the malacia. That being said, a CT scan certainly gives you additional information. It can tell you if there's any anatomic variants. It could tell you if there's any inflammation that you may not catch on a bronchoscopy. And I do think you gain very valuable information from the CT. But for me, if I'm going to operate on a patient, again, I'm thinking as a surgeon here, I'm always going to do an awake bronchoscopy because I think that provides some additional information that may be overlooked on a CT scan, especially if it's not timed properly.
That makes total sense. So you alluded a little bit to it earlier, but let's talk about the use of airway stents in the evaluation of this disease entity. So they can be used to both determine the extent of EDAC or TBM to contributing to a patient's overall respiratory symptoms, and potentially estimate the potential benefit of definitive tracheal management, at least in theory. And of course, there's been a number of different kind of clinical experiences and suggested algorithms that folks have published looking at specifically, how to use these airway stents. But what are your thoughts on the use of airway stents in EDAC? And do you think that all patients actually need a stent trial prior to considering definitive tracheal surgical management, or not necessarily?
Well, I will say now, I say not necessarily. But when I first started doing this, I was, again, insistent on everybody getting a stent trial. I think the problem with stents is that they're not risk-free and they're not a completely benign intervention. Many patients end up having stents and they end up coughing more, or they have increased secretion burden. So really, the application of stents really depends on what the patient's primary symptoms are, or if I'm really confused as how much their central airway collapse is contributing to their symptomatology. So for example, patients who come in primarily with cough, if they have a convincing CT and awake bronchoscopy, I really don't think a stent trial is helpful for them because often patients are burdened by this. They're more irritated, they cough more, they have more secretions, and it really confounds what you're looking for as your output. I think the same for patients who come in primarily with infections. And again, I recognize there's overlap here, but the one group that I still do stent trials fairly routinely are those patients who come in with dyspnea. And for these patients, there's a couple pearls that together we've figured out over here at Penn. Number one, shorter duration is better. Initially, these stent trials were described for up to several weeks. Now we tend to put these stents in on a Monday or a Tuesday. At that time, I'm often around and I look for the wake bronchoscopy at that time, so it minimizes some of the burden on the patient. And then that we leave the stents in for just 3 or 4 days. So the stents come out at the end of the week. So really, we just want the stents in there for as short a period as possible to eliminate any of those potential risks down the road. And I'll say before the stents go in, and then just before removal, we do objective testing, and we do a 6-minute walk test and then PFTs. And I think for the majority of these patients, we don't need to see a dramatic improvement, but we do like to see an improvement. But again, we recognize that sometimes stents can cause more problems, coughing, secretion burden, and other problems. And stent migration is something, unfortunately, we've encountered. I think it's much, much better. We no longer use the plastic stents, we use metal stents, and I think that's improved some of the issues that I had previously described. But again, for that group of patients, again, the patients that primarily have dyspnea as their symptom, I still feel stent trials are pretty important. But again, short stent trial, objective testing before and after stent placement. And I think the metal stents, especially those stents being placed in the areas that you're going to attempt to stabilize, is critical.
That makes perfect sense, and definitely understandable given the the confounding issue with stents causing cough and causing discomfort sometimes. So definitely understandable to perhaps not think that they're quite as useful when the primary symptom is coughing. So Jarrod, you are one of the few thoracic surgeons in the country who's received specialized training in tracheal bronchoplasty and tracheal resection. So could you walk our listeners through when you consider each of these surgical interventions and which patient and anatomic considerations most influence your decision making? And feel free to kind of tell us whatever details you think us interventional pulmonologists might be able to comprehend from a surgical management standpoint.
Well, it's flattering that you say that this is my decision, but the reality is, as you know, Roger, we're fortunate, especially here at Penn, once a month, every Friday, there's a group of us who get together. It's thoracic surgeons, it's interventional pulmonologists, it's otolaryngologists, it's pulmonologists, and we make these decisions collectively. But, from a surgical perspective, I think the most important consideration, at least I'll start with TBM or EDAC, is that this patient's been optimized. And as we said earlier in this conversation, there's a lot of comorbidities that can be present, or there's other diagnoses that could mimic TBM. So a lot of these patients come in with comorbidities. Obesity is one of them. I'd like to have patients sort of as fit as they can be. I recognize that many of these patients have been on steroids for years, or they have other issues that limit their ability to actually lose weight, dyspnea, shortness of breath, infection, etc. So I like to make sure that, those things are worked up as best as possible. Reflux is another problem that I see in these patients. And unfortunately, we have a very good GI team over here. And some of these patients, believe it or not, we've actually done fundoplications on before we take them to the OR. And some of the patients have actually responded pretty dramatically, and their cough has disappeared after treating their reflux. So I think one of the most important things is, again, sticking to that multidisciplinary team and making sure other comorbidities are either maximized or ruled out as contributors to what the patients are presenting with. In terms of anatomic considerations, I kind of hinted on this. There's a couple things that I think are important. When we do this operation, whether it's open or with the robot, we really only can stabilize the mid to distal trachea and then the main stem airways down to the lobar airway. So if there's more significant distal disease, whether it's bronchiectasis and some parenchymal disease, that's never going to go away. So I always question, does it make sense to do tracheal surgery where we sew a permanent mesh to the membranous wall of the trachea? Is that worth it? And then do the ends justify the means? So you got to really know your patient's comorbidities and what the pathology is, because we're really only fixing a certain part of the patient's airways and their pulmonary system. And I think for Malaysia, it's important to really have clear expectations with your patients, because we make patients a lot better, but we don't make them perfect. And I think that's something that patients really need to understand. A lot of these patients are so debilitated at baseline, they have difficulty getting out of bed and, walking up a couple flights of stairs or even walking around the block. And I think we can certainly make these patients better. And I've seen that. That being said, it's not a perfect fix. And I think really understanding what the patient is capable of having at the end of this is important for the patient, but also for the surgeon and the team. Obviously, if a patient has other extreme comorbidities, if they have difficulty, I saw a patient the other day with MS and she's with a walker and obviously she has significant dilation, but for me to put her through that big operation, I just don't think that I would ever make it such that she would be able to really gain a ton of benefit because she's limited by other comorbidities. So I really think clear expectations, understanding the anatomy, understanding if there's other processes involved, that's all really, really important. And although tracheal resection is a different pathology, I think the same holds true for that. You got to know your patient and you got to know what your surgery is going to be able to provide in terms of a benefit, because these are serious surgeries. And although we have great results here and great results have been reported elsewhere, these are really significant interventions and a complication can be devastating. So again, the ends have to justify the means.
Absolutely. And can you tell us what a typical kind of recovery looks like for a patient who undergoes one of these operations? How long are they staying in the hospital? What are the kind of metrics you're using to gauge success and to kind of follow them up post-operatively?
Yeah. So when we do these resections, or I should say the tracheoplasties robotically, it's no different than a lobectomy. I remember the first time I did this here, and everybody was shocked, but the patient came out of the OR and the patient had a chest tube. Chest tube came out on day 1 and the patient went home on postoperative day 2. And that's pretty much the standard. Again, minimally invasive surgery has changed the way that patients recover from the perioperative event. And I would say that holds true for tracheal bronchoplasties. Most of my patients are out of here within 48 hours and they do remarkably well. And I think if you pick the right patient, especially the patients with cough, pretty much right away if you had a good result, on the postoperative bronchoscopy, if that membranous wall isn't moving, if you have reconstruction of that cartilaginous configuration, and patients know within 24 to 48 hours in general. And that's been really, really impressive. But the recovery is pretty straightforward. And if we approach these things with a thoracotomy, patients are generally in the hospital around 3 or 4 days. But we've gotten pretty good about doing these things robotically, and I'm really proud of that. And in terms of recovery, patients sort of drive this. Patients are usually able to be active pretty quickly, and they feel great, and they listen to their body. And in terms of objective testing, I get 1 CT when they come back, just because I'm interested to know what the repair looks like and understand exactly what the anatomy is. It's just a good old-fashioned CT chest, no dynamic airway protocol. It's just a straightforward CT, so I have a baseline, and I don't chase them. I don't chase objective data, at least at this point I don't, because patients have really done well, and I wouldn't intervene if patients are doing better, their dyspnea is improved, their infections are better. I don't think that there's a whole lot to be gained from that. So in general, I don't have a protocol. I just follow the patient clinically, and if there's any problems, then we tackle it after that. But in general, most of my patients have been out, or I should say some of my patients have been out for almost 1.5 years or 2 years since I've started doing this. And, knock on wood, the results have been pretty good.
That's amazing. And what do you think are the most important questions to answer next in the world of central airway collapse and, tracheal bronchoplasty?
I think the question is what happens in the long term, when this is a relatively new phenomena. Obviously, tracheal bronchoplasties have been around for many, many years, but Rich Lazaro, who's really the one who pioneered this with the robot, and also Sidhu Kengadaran, these are 2 guys that made this widespread, and I'm just following their lead. I don't know what's going to happen in the long term. I think that these are going to be durable repairs. The data seems to suggest that up until 5 years, it's durable. Over time, I suspect that we use a permanent mesh, not much is going to change, but we'll have to see over time how this pans out. But I do think that the stabilization is going to be a persistent one. Is there going to be a problem when a permanent mesh is in the, suture to the membranous wall over decades? We don't know. These are unanswered questions. But in terms of moving forward, we've done a really good job of managing patients with relatively stereotypical EDAC or TBM, but there's a whole group of other patients that we still can't do very much surgically for. I'm sort of referring to the patients with RP or other processes where, they don't have a intact or at least somewhat intact cartilage scaffolding for us to work off of. So I know Rich is interested in other different modalities, and he's actually working on some of these things now. And I think that's the next step, because right now we have a way to improve many of these patients, but there's still a group of patients that tracheobronchoplasty or stabilization of that membranous wall just doesn't do very much for them. So I hope in the future we could come up with better ways to help palliate those patients as well.
Well, thank you so much for sharing all that, Jarrod. It's time for closing remarks. Anything you feel we left out that's important to discuss?
No, I think that's really, we covered a lot of ground over here. I think that this is, as you said early on, this is probably an underdiagnosed phenomena. And I think the most important thing is to know it exists. And when you have complicated patients, a simple dynamic CT gives you a lot of information. And obviously, I insist on an awake bronchoscopy, but a dynamic CT is certainly something that helps you figure out if there's any other anatomic issues that are going on. And there's been plenty of patients over here at Penn that, people were stuck and they didn't know what was going on with their patient. They got a dynamic CT, and lo and behold, they had a misdiagnosis of asthma, for example. And we ended up doing a tracheoplasty, and the patients have derived a lot of benefit from that. So I do think it's an underdiagnosed entity, and I think that knowing is half the battle. And once you have this diagnosis, there's plenty of referral centers, and I know that we're happy to work with anybody to try to figure out how to take care of these patients. But the final thought is it does take a team. These patients are often very, very complicated, very, very sick patients, and the ability to identify this process and actually fix it in a minimally invasive approach has really changed the landscape. And I think the future is very, very bright for this entity for sure.
Well, thank you so much again for your time, Dr. Predina. I know I certainly learned a lot from you today, and I'm confident that our listeners have as well. So thanks again.
It's a pleasure, Roger. Thanks for having me.